10 minutes, anemia. Yes, in this video, I will be discussing the entire anemia pathophysiology, the main mutations, and the treatment options that we have for all the diseases of the RBCs and anemias. Are you ready for it? Go for it. Yes. To talk about the anemia, the first thing to understand is the basic RBC morphology. Yes, the RBC is a biconcave in nature and they have a central pallor. Now, RBCs have something called reticulocytes, which are called as immature RBCs. Remember, the bone marrow has proerythroblast, and then comes a mnemonic BPO, basophilic, polychromatic, and the orthochromatic erythroblast, which give rise to polychromatophil, also called as reticulocytes in the blood. So this is a reticulocyte stained by a supravital stain, like new methylene blue, Brilliant blue, and the crystal violet. Okay, high retic count is hemolytic anemia. Low retic count is either a hypochromia anemia, but a normal retic count will be seen in most of the cases of normocytic normochromic anemias. Okay, now the first type of hemolytic anemia we'll discuss here is what is called as hereditary spherocytosis. So what should you know about it? Yes, it's a type of mostly extravascular hemolysis having an autosomal dominant index. What you notice here is this is a spherocyte, which is mostly due to the AN carrying mutations, more common than the band 3, more common than the spectrin mutations, because of which there is a decrease in surface area, and therefore, why decrease surface area? Because the spleen removes it and becomes a spherocyte, ultimately destroyed by the spleen. Remember, the most common gene mutation causing hereditary elliptocytosis is spectrin, but the most common or the maximum hemolysis occurs in the alpha spectrin loss. Now, the second one is diagnosis. You can do it by OFT, and remember the OFT is increased here. Ectocytometry, also called as EMA diagnostic test, is a new test for diagnosing the case of hereditary spherocytosis. Okay. Second one is a G6PD deficiency. What you see in this image here is actually what? It's a Heinz body. Why are they formed? They are formed due to the oxidative damage to the hemoglobins. Well, increase H2O2, they will damage the hemoglobin, and that will lead to formation of water and H2O. But in absence of the G6PD deficiency, or in absence of G6PD, what happens? This hemoglobin gets oxidized, and that oxidized hemoglobin, it comes on the membrane, and that is what leads to a Heinz body. The Heinz body, when removed, they lead to something called as, yes, a bite cell. Now, what you must remember is there's some drugs which will increase it, like primaquine, chloroquine, quinine, sulfur drugs like fluoroquinolones, raspberry-case, and vitamin K. Now, the few foods like fava beans, and hence it is called as favism. And infections can also lead to increase in the G6PD levels, causing more and more hemolysis. You treat them by avoiding these inciting events by a bone marrow transplantation or an allogenic transplantation. Next one is what is called as a thalassemia. Well, thalassemia can be alpha or beta thalassemia. Remember the type of the alpha and the beta gene. Alpha is on chromosome number 16 and beta is on chromosome number 11. So what happens in this thalassemia is basically there is an absence or a mutation of the gene in the beta thalassemia, alpha gene and alpha thalassemia. Now the main mutation in the beta thalassemia is a missense pathogenic mutation, while the same mutation in the alpha thalassemia is mainly due to deletions. Okay, very important. Secondly, know about the main pathophysiology. It is mostly due to extravascular hemolysis. It leads to an increase in the HbA2 and the HbF amount. Well, HbF increasing causing tissue hypoxia, and that is what causes the typical hemolysis occurring in the case of thalassemia. One more thing to understand is it leads to a thalassemic phase, and it leads to what is called as crew cut or a hair on end appearance. Don't forget the typical RBC morphology, including the polychromasia, microcytic hypochromia RBCs, target cells, Howell jelly bodies, nuclear RBCs, cabot rings, and not to forget this very, very importantly, what you see is a basophilic stripling, which is actually due to the abnormal hemoglobins. The screening test for this is Nestroft, and the mutation can be diagnosed especially with the help of genetic analysis. What also helps is hemoglobin HPLC, but should be done for both the parents as well as for the child. Next one, this is a cabot ring. Okay, this is a cabot ring as you see here. Next one is sickle cell anemia. Well, sickle cell anemia is a missense mutation again in the beta gene at the 6th position, because of which glutamic acid is replaced by the valine. So what are the findings? When we see a reversal sickling, you get a hand-foot syndrome, the most common finding, congestion causing increased chest infections, and bone causing osteomyelitis. You get retinopathies and papillary necrosis, which becomes an irreversible change. Late in the disease, what you can get is autosplenectomy, which is causing a splenic atrophy like this. Well, there's something called as irreversible sickling, in which the damage occurs more and the entire RBC shrinks to what is called as the sickle-shaped RBCs, ultimately causing extravascular hemolysis. The treatment again options is allogenic stem cell transplantation. Before we move forward, you should also remember what is called as PNH. Well, PNH is actually a disease when you find an absence in the PIGA gene, because of which the GPI anchor protein is absent. This causes also loss of CD55 and 59, causing excessive activation of complements. That is what leads to lysis, and is diagnosed by an acidified serum lysis test, HAMS test, sucrose lysis test. A flare is also to diagnose it, and not to forget a global standard being a flow cytometry showing absence of 55 and 59 in these cases. Okay, this is what is you see in PNH with the absence of 55 and 59 in the RBCs. Now, there's something called as immune hemolytic anemias, which can be cold or can be warm. A cold antibody hemolytic anemia is due to IgM antibody, and the warm IgG is garam. So IgG antibody causes warm. Different etiologies for cold: remember the infections, especially the Mycoplasma pneumoniae, and the warm antibody mainly due to the drugs or can be the lymphomas, and it is seen in some autoimmune disease also. The treatment options surely being steroids, and the RBC morphology you see is called as a spherocyte. Moving ahead, we have a case of iron deficiency anemia. Well, in its anemia, what you get is a microcytic hypochromic RBCs, and the main finding you see is because of 4 reasons. Number 1, diet deficiency, malabsorption, or it can be a case of parasitic infections, or can be severe loss like in menstruation. Now, in case of iron deficiency anemia, what you get is a microcytic hypochromic RBCs along with what you get is target cells. Not to forget, the pencil cell is very specific for iron deficiency anemia. In this case, you can differentiate them by the anemia from disease. Remember, both of them have low serum iron. They both have low transferrin saturation. So what differentiates them is a TIBC and ferritin. Very simple. In IDA, ferritin is low, TIBC is high. And in ACD, ferritin is high and the TIBC is low. A simple way to differentiate them. Next one here is called as macrocytic anemia, in which you get a macrocyte. Remember, the hyperpigmentation often seen in this case, and what you see is a colocytic change in the iron deficiency anemia. What you see is a hypersemitic neutrophils. You get a macrocyte, a macroovalocyte. You get a Howell-Jolly bodies. You can get a Cabot rings, and you can get also a teardrop RBCs in a macrocytic anemias. Remember, they have mild hemolysis, but what you don't have, yes, what you don't have is a high retic count. Yes. Now, in case of a bone marrow, what you get is a macrocytic or a megaloblastic anemia having high NC ratio and an abnormal NC division. That means there is an immature nucleus with the maturing of the cytoplasm. That's very important finding, and hence we call it nucleocytoplasmic asynchrony. They often shows pancytopenia with a hypercellular marrow in the bone marrow. Okay. Lastly, you see a normal marrow. This is a normal marrow. This is a bone. This is a fat, and you see here these all areas are the normal cells. Well, in aplastic anemia, what happens, there's a pancytopenia, and along with that you get a hypocellular marrow. So pancytopenia along with hypocellular marrow becomes aplastic anemia, but the same thing if you find is a absence of erythroids in the bone marrow along with only severe anemia is called as pure red cell aplasia. Remember, a PRCA has a very important finding you see in a parvovirus B19, which occurs mostly in a case of severe infection along with the hemolytic anemia. I'm very sure guys, you might have all liked this video. If you really like this video, let me know, and let me know the next topic you all want. I'll surely revise this in the next 10 minutes, ensuring that you don't miss anything. God bless you all. Goodbye.